Good morning, everyone, and welcome to Ask Dr. Mingle, a production of Mingle Health where we attempt to bring brevity and clarity to Medicare's quality payment program and other topics on value-based healthcare. I'm Dr. Dan Mingle, family physician, CEO, and founder of Mingle Health. I'm hosting this, our final Rule 2024 edition. Dissecting the rules is a team effort here at Mingle Health. My guests today are our in-house subject matter experts. First, a few of my comments. In the annual rulemaking exercise, Medicare is continually tweaking program rules and details. Even if the measures and activities you have used successfully in the past are retained, don't expect them to be unchanged. Review the new specifications early in the year to be sure you are aware of any changes that might threaten your continuous great improvement. Work any changes early into your processes, procedures, and your staff training. At a high level, what I see in this final rule is perhaps the most important thing. As the deadline approaches, Medicare refused to postpone the sunset of the web interface. Instead, Medicare offers the new collection technique, Medicare CQMs. Of second importance is some covert but important modifications to their digital quality measure strategy. Since they announced the strategy, the market has mostly equated digital measures with ECQMs. At this point, I don't think anybody knows, including Medicare, if that particular narrowing is inevitable in the strategy. Those covert messages in this rule, health IT vendors have been removed from the list of eligible third parties that can help you submit your QPP quality measures. They have confirmed the pivotal place that registries hold in the quality measure process for CMS. For a health IT company to continue to help you, they have to qualify as a registry, either a qualified registry or a qualified clinical data registry. And the new Medicare CQM data collection type is based on the classic registry specifications contained in MIPS CQMs, not on ECQM specifications and processes. Part of the covert message, while they do not commit to a future of all ECQMs or all MIPS CQMs, they clearly stated that web interface grounded in manual chart abstraction is not digital quality measurement. Less development has occurred in what is now being called traditional MIPS in favor of substantial efforts continuing to develop more MIPS value pathways. And continued efforts are underway to make it more attractive to practices to participate in the Medicare Shared Savings Program accountable care organizations, with a continued reminder that Medicare wants 100% of Medicare beneficiaries to be in an accountable doctor-patient relationship by the year 2030. Now, enough for my summary remarks. Let's get to the specifics. First up from the Mingle Health team is Lisa Morin. Thanks for joining us, Lisa. We're delighted to have you here.
Well, thank you, Dr. Mingle. It's a pleasure to join you and all of our clients and folks here today.
I understand your topic of focus is promoting interoperability. That is the PI category. What are the most important elements you want to bring to our attention about the PI category?
So first and foremost, I think it's important to call out that there's no new measures in the MIPS promoting interoperability category. And there's also no changes to scoring. Having said that, there are a couple of changes that could impact our clients quite a bit. One of those being the reporting period in 2024 is actually going from 90 days to 180 days. So that could be significant for folks. We have a couple of other changes that I think are pretty minor. There's a modification to the prescription drug monitoring program measure. There's a minor change, more of a clarification and update to the electronic prescribing measure. And then another one that folks need to pay attention to is the SAFER guide is now required. That has been a measure in place for the past 2 years, 2022, 2023. But in 2024, previously they would just say yes or no, whether or not they have completed just the high priority practices guide of the SAFER guide. In 2024, they will have to say yes, that they have done the high priority practices guide. So it's still the same measure, but they do need to complete that. And a reminder that that's in addition to their security risk analysis.
Lisa, just a clarification on that. Are they requiring it to be done or read?
They have to have done the high priority practices guide. Um, in the measure spec, if you click on that, there's a link to the ONC website, and it brings you to the worksheet, the checklist, and the associated worksheet that clients can fill out the self assessment guide fairly easily.
Thank you very much. Now, my next question, with the minimum PI reporting period going to 180 days, what effect do you expect that to have on our practices?
Yeah, so I think that's a pretty big change. So I think for anyone who is considering upgrading, changing, or working on some improvements in their program, they need to plan ahead. Because in the past, if they were reporting a 90-day period, if they were changing from one EHR vendor to another, they could report from the old EHR vendor prior to upgrading or work on getting updated and then report from the new vendor. 180 days is a big block of time to report on. So they're going to make sure that they have planned that ahead. Another big piece of this is that there are a couple of measures that are numeric measures where there are exclusions if there are less than 100 patients. So, electronic prescribing, or the two health information exchange measures, the sending of health information, the receiving of health information. I know a lot of our practices have been excluded from one or both of those measures because they meet that 100 patient minimum for the exclusion. Um, the exclusion hasn't changed, so now that they're reporting on 180 days, it may be unlikely that they can use that exclusion. So, looking at those numbers, identify, first of all, if they're going to need to report, and then making sure that they are either reporting well or can report at all in those measures.
Do I understand that correctly then that the 100 patient minimum applies to your reporting period?
Yes,
Whether you choose 180 days now or a full year or something in between, um, you're still at 100 patients minimum to exclude from that measure.
correct.
Okay. Thank you. Now, I understand there's a new naming convention for certification editions. What's that about?
So the ONC has proposed some changes to the certification editions. In the past, we had certification editions that were based on a year. So the 2011 certified edition, 2014, 2015. Right now, we're using the 2015 certified edition Cures Update. What CMS is proposing, based on what the ONC is proposing, going away from those additions and doing a base criteria with regular and ongoing updates. So it's really the Office of the National Coordinator that is overseeing the ONC. Managing and doing those updates. CMS is also trying to get away from within the QPP program of listing out each and every change and really directing people to the ONC site for any changes. We know that that might be hard for folks to follow and understand what they need to do to understand what the rules are, understand that they're in compliance. But that's really pointing towards the ONC to try to manage that versioning and education around that. Hopefully, going forward, that makes it a little easier and cleaner. And I am really hoping that the ONC is able to provide some additional education to help people understand what they need to do to comply.
Thanks, Lisa. And finally, there's always been some practices, some providers who are excluded don't have to respond to promoting interoperability. As of the 2024 performance year, who still gets an automatic exception from PI?
And that's a great question, and that's another big piece of the PI program for 2024. As of 2024, it's only clinical social workers who are going to get that automatic exemption as far as provider types. So for 2024, previously there were a large number of provider types that were excluded. So in 2024, No longer excluded are occupational therapists, physical therapists, qualified speech language pathologists, qualified audiologists, clinical psychologists, and registered dietitians or nutrition professionals. So practices really need to take a look at who is set up for MIPS reporting, who's using their electronic health records, and consider that as they're planning ahead. Keep in mind there are still a number of practice types, a number of special statuses that still allow for automatic reweighting. So if you're a small practice, that is a category where you can still continue to get automatic reweighting in the PI program, as well as non-patient facing, hospital-based, and ambulatory surgery centers. So those are folks that don't necessarily need to report the MIPS PI program. But planning ahead, looking at your options, working with your consultants to try to understand if there's some changes that are impacting you, and whether or not you might want to consider using the hardship exemptions that are continuing to stay in place. But you really do need to have good justification, and we can help you sort that out.
So one of the outs that our clients who might be adversely affected by the change to 180 days, they might qualify for a special exception for that year.
They might. They have to really plan ahead. That came up loud and clear in the final rule with the comments. Um, CMS really is putting the onus on practices to kind of plan that out, but understand that if you do have some issues with your implementation and things get behind, you have some issues with that implementation, certainly that hardship exception is an option available.
Well, thank you, Lisa. It's been very informative.
You're very welcome. Happy to assist.
We've also have with us today Maryellen Thoma. Thanks for joining us this morning, Maryellen. We're delighted to have you here.
Thank you for having me. Good to see you.
I understand your focus is improvement activities. To start, what are the most important things you think for us to know about improvement activities for the 2024 performance year?
For improvement activities this year, there were, or I should say in 2024, there were no changes proposed in the policies related to improvement activities. There were some changes in the inventory. 5 new activities have been added, 1 modified, and 3 activities removed. There's also one of the new activities is focused specifically on quality improvement for practices or subgroups participating in MVPs. And I guess the final advice or a reminder is to plan early when you're looking at choosing activities to attest to, because preparation and having the documentation in place will help when it comes to a potential audit.
Remind us, Maryellen, of the core requirements of improvement activities.
So as an overview, there are over 100 activities to choose from. Practices must attest to participation in activities depending on any special statuses that apply. It's a combination of high and medium weighted activities to earn full points in the category. Each measure has guidance or what we call data validation related to the documentation that is required when you attest to an activity. And it's important to keep that documentation in place for 6 years because CMS does reserve the right to audit this category. In terms of other requirements for improvement activities, it's a 90-day participation requirement. And for groups reporting, at least 50% of the clinicians billing under the tax ID must be able to attest to participation in the activity for a minimum of 90 days each.
Thanks, Maryellen. Now, as MIPS value pathways ramp up, how do improvement activities work in MVPs?
There is a flexibility that's introduced to MVPs as compared to traditional MIPS, and that is, first of all, you need to select or attest to the activities that are within or defined, or prescribed within your selected MVP. And the activities weighting or scoring is doubled within MVPs, so you'll need one high or two weighted activities chosen from the list available within your MVP.
So, and is the 50% threshold of providers required still in the MVPs?
That it is. They actually, the rule addressed that would include subgroups as well. So the threshold for subgroup would be 50% of the clinicians participating at the subgroup level.
All right. Well, thank you very much, Maryellen.
Thank you.
Very informative.
Thank you. Appreciate the time.
My next guest this morning is Brigid Whitney-Gallagher. Welcome, Brigid. We're delighted to have you with us this morning. You are our resident expert on the MIPS quality category. What are the most important take-home messages for quality reporting in the 2024 final rule?
Good morning, Dan. Lovely to chat with you. So 2024 related to quality. We don't have a lot of new regulations or anything like that. What we are seeing is a continuation of the trend in quality that we've seen in previous years, which is really around the measure inventory. We have some new measures. We have 11 new measures, 11 measures that were removed. We have 3 measures that were removed for traditional MIPS but are still available as part of MVP reporting. And almost 60 measures have seen some significant changes. So the take-home message is think about measures early. There are lots of factors at play. Measures have changed year to year. What was successful in previous years may need to be looked at again, and consider scoring when you're thinking about what measures make sense for your practice.
Thanks, Brigid. That was very helpful. You should never assume that your measures, even if they're still available, are the same this year as they were last year. Be sure you check the specifications to make sure you're recording it correctly, to make sure you'll get the credits you need. And the benchmarks may have changed, so it's not, even if you score the same, it might not, even if you perform the same, it might not score as well as it did last year. So, Brigid, what about the basic requirements for scoring for 2024? First, what is the new performance threshold proposed to be? Or finalize that. Thank you.
Yeah, so the performance threshold for 2024 reporting will be 75 points, and that means you will need to earn 75 points in the MIPS program to be held neutral from any payment adjustment.
Great. And how about the data completeness threshold?
Yeah, data completeness is another one that had just a little bit of a change. It went from 70% to 75%. So that means as you're reporting on a patient population for a particular measure, you will need to report on at least 75% of those eligible visits to earn points in that measure.
All right. Now, is that going to last for a while, or going to change again next year?
So the data completeness that is reporting on 75% is set to remain at 75% through 2027. So CMS is committed to not increasing that for a few years. The 75 points to avoid a penalty could continue to change. We expect to see that reviewed by CMS every year annually as they move forward with this MIPS program.
But Brigid, can we be absolutely certain they won't change their mind next year and start increasing that completeness threshold anyway?
I feel quite certain it is finalized in the 2024 final rule. So, barring something like a health emergency, as we saw with COVID, the rules that are finalized tend to stay. So, assuming we don't have any public health emergencies, I think we can count on that 75% reporting.
All right. Thank you very much. Now let's move on to MVPs. You're our resident expert on that as well. So, what are the most important couple of changes you see in MIPS value pathways for 2024?
Yeah, great question. CMS has done a really good job investing in MVPs as a pathway through reporting. They have added 5 new MVPs, which makes MVPs accessible to more specialties and more practices. If you recall, in 2023, we had 11 MVPs. Those all still stand. So we are up to a total of 16 now. But the 11 that were in place in 2023 have had some changes. So it's really important, just like we talked about in quality, to review the specifications, look closely at what the different MVPs are including. Measures have changed a bit over the year.
Thank you. And what are the 5 new MVPs?
Yeah, so we have focusing on women's health, quality care for treatment of ENT disorders, prevention and treatment of infectious disease, including Hep C and HIV, quality care for mental health and substance use disorders, and musculoskeletal care and rehab support. So a wide array of different specialties, and hopefully that combined with the 11 MVPs that have been in play, there is an MVP for lots of different practices, and it's worth exploring.
Great, thank you. Now, there's a cost category in MVPs. How does that differ from cost in traditional MIPS?
Yeah, that's a great question. So, in traditional MIPS for cost, you practice, however you're submitting, a practice or an individual could get scored on any number of cost measures. And it depends on how CMS determines the practice to have eligible patients for each different cost measure. There are, I think, 25 cost measures out there. So it can be a little bit hard for a practice to know if they're going to be subject to this cost measure or that cost measure, et cetera. With MVP, you get a smaller subset of cost measures. So if you have patients or encounters that are eligible for that smaller list of cost measures, then cost may apply to you. But if you don't have patients who are subject to cost for those particular measures, cost doesn't apply to you. Really, using an MVP in the cost category can be a way to limit the amount of cost measures that may apply to your practice. And that could be a good scoring strategy for some folks.
Well, thanks, Brigid. That sounds like good advice. Now, how do improvement activities fit into MVPs?
Improvement activities in MVPs work similar to how they work in traditional MIPS. The group or subgroup or individual chooses the improvement activities they want to report. The difference is in an MVP, each MVP has a list of specific improvement activities that are available for selection, and you're not able to select improvement activities that haven't been made part of that particular MVP. This could be burdensome, but IA, that is to say improvement activities, all those points are doubled when you report as an MVP. So you may only have to do half as many activities as you would through traditional MIPS. So there are some benefits in there as well. There also is a new improvement activity related to participating in an MVP. So that might be worth exploring.
Great. That's very interesting. Now, Brigid, has CMS defined yet the date that they plan to sunset traditional MIPS and fully adopt the MVPs?
They haven't, Dan. They have in previous years made some predictions. We have seen no further detail on that. I think we have a long way to go before sunsetting traditional MIPS and fully adopting MVP would be a viable option. But certainly we pay attention to everything CMS says and really look into that information so we can share it with our clients. At the moment, we have no further information and nothing to indicate that that's going to be happening anytime soon.
So Brigid is also our resident expert on the cost category. Brigid, what's new and important in the cost category?
Yeah, so for 2024, there are some new cost measures that everyone should be aware of. These are episodic cost measures, which means in order for these cost measures to be applied to you, you would have to have 20 episodes of care related to these measures. And the measures are inpatient psychosis and related conditions, depression, heart failure, low back pain and emergency medicine. Also, new in 2024 is that the simple pneumonia cost measure has been removed. And this was just because of a coding change. Because of the way visits like that are going to be coded, it is next to impossible to determine if a patient should be included in that measure. So they've decided to retire the measure.
Great. Thanks, Brigid. Now, I understand there's a bonus for improvement in the cost score. How does that work?
Yeah, this is pretty exciting. So, there is bonus available for improvement in cost. Originally, CMS had indicated that they would like to have this bonus applied for improvement on a specific cost measure. However, what they have finalized is that any improvement in the cost category could make a practice eligible for the bonus. 2023 is actually the first year that this improvement bonus is available. And the reason for that is because 2022 was the first year that scoring and cost was included in the MIPS final score. So now we have something to compare things to. We can find improvement, which is great. So the way the bonus works is you can earn up to 1 full point out of the possible 100 you can earn in cost. Can't be negative, so this can only help you. And if you are perfect in cost anyway, if you already have 100%, you can't do better than that. But for most folks, having that improvement bonus can really help in a couple different ways. You're getting credit for the good work you're doing, which is always a plus. And it can give a little boost to your score, which ultimately helps everyone.
Great. Thanks, Brigid. So I take it that if you earn your 100 points in cost with the bonus included or not, that then translates to the 30 possible in the overall score. So it's 30% next to 30% quality.
Absolutely right. So that 1 point for the improvement bonus and cost helps practices earn as many points as possible in the entirety of the cost category when we look at all 4 categories in MIPS.
Thanks a lot, Brigid. I appreciate your help.
Thank you.
Tracy Game is our resident expert on the Medicare Shared Savings Program. That is the MSSP.
Hi, Dan.
Good morning, Tracy. What are the most important changes you think for the Medicare Shared Savings Plan for 2024?
Well, Dan, there are three that I would point out that people need to be aware of. First is Medicare refused to postpone the sunset of the web interface. 2024 is still the last year for that reporting. Second, Medicare introduced the new Medicare CQMs to address the concerns of ACOs about the transition from web interface to a registry reporting. And third, they finalized but postponed until 2025 a requirement that 100% of advanced APM participants use CERT, that all APM participants, MIPS, QP, and partial QPs, submit and be scored on PI, with the usual automatic MIPS exclusions applying.
So, Tracy, how have the APP options changed?
ACOs can still use the web interface for 2024. Starting in 2024, Medicare CQMs are an option along with the previously established eCQMs and MIPS CQMs. There is still a favorable quality standard in 2024 for those submitting MIPS CQMs or eCQMs.
So that doesn't apply, we think, to the Medicare CQMs.
That's correct.
So how are the Medicare CQMs specified? What are they?
They share their MIPS CQM specifications. They require the assistance of a qualified registry. They cannot be done as eCQMs. The numerator, which is the performance, specifications are identical to MIPS CQMs. The denominator differs from MIPS CQMs. With the Medicare CQMs, it's not all patients, all payer. It's limited to Medicare Part B, fee-for-service patients, but it only includes patients seen by a primary care provider.
It sounds like a little like what we used to do in PQRS, but limited to the primary care patients in the ACO.
That's correct.
So, Tracy, are the patients who are eligible for Medicare CQMs the same patients that are on an ACO's assignment list?
No, it's all patients seen by a primary care provider participating in the ACO. There should be overlap between the assigned and eligible population, but you can have assigned themselves prospectively to an ACO primary care provider that did not have a primary care visit in the ACO. And the submission will include patients who were seen at least once by a primary care provider, but were either self-assigned as a patient of a different ACO or were assigned by the priority of care rules to a different ACO.
So I think what you're saying is that it doesn't matter who they're assigned to. If they were seen by a primary care provider in the ACO, they'll be included in the report. And if they weren't seen, they're not going to be included.
That's correct.
I think I've got it. Now, how is this better for ACOs? How is the Medicare CQMs better for ACOs than the MIPS CQMs?
Three things, I think. It should be easier to deduplicate the smaller set of patients. Medicare promises to help by providing a quarterly list of eligible Medicare patients. It also, if an ACO needs to resort to chart abstraction for some of its practices in order to meet data completeness, it's a smaller set of charts that will need to be abstracted. Less time for them devoted to having to pull patient charts to report this data.
Makes sense. I get it can be a big help, I think. Now, does a practice submitting Medicare CQMs have to use Medicare's provided list?
No, not at all. Medicare's provided patient list is only a guide. The gold standard for determination of denominator for Medicare CQMs is still practice claims data.
Tell us more about the CEHRT requirements that are changing for APMs that you alluded to in the first question.
So, yeah, it has been postponed until 2025. Starting in 2025, all advanced APM participants are required to use a cert. All APM participants will be required to make a promoting interoperability submission. Promoting interoperability requirements will be the same as for MIPS, including the applicability of exceptions and options for reporting, including individual, group, and APM.
Great, thank you. And I understand the assignment methodology has been adjusted. What's changed?
There's a third step now to assignment, but for those patients who are still assigned in the two steps as they currently exist, there's an additional 1 year look back for patients who saw a primary care physician in the prior year, but not in the current year, and saw a non physician practitioner in the practice in the current year.
So it sounds like they get 2 years now to see a primary care physician in the practice, but have to be renewed by at least either the physician or one of the non-physician practitioners to be assigned in that third step.
That is correct, Dan.
Well, thank you, Tracy. You've been a big help.
Thank you.
My thanks to the whole team for all the great insights, and thanks to all of you for tuning in to make our work worthwhile. We want to be helpful, and we want this to be useful to you. Don't hesitate to correct or supplement our answers, share your experiences, ask your questions. We can be smarter together.